Can you all hear me? Sorry, I know you're muted. I know you're all muted, but sir, can you hear me?
Yes, I can hear you.
Okay, so my name is Dr. Mariam, and I'm going to be taking you through the O&G MCQs. So let's start. The first question here says, concerning development of the ovary, pick the wrong answer. Okay, so A says granulosa cells in the corpus luteum are responsible for steroidogenesis. B says Tweaker cells are not responsible for testosterone synthesis from cholesterol. Of course, this is correct. C, meiosis resumes prior to FSH surge. As well, this is true. Then D says third polar body is released prior to LH surge, which is also correct. So the wrong answer here obviously is A, because granulosa cells are not responsible for steroidogenesis. Corpus luteum cells excrete progesterone. Then second question says, in embryo development, A, beta HCG is produced by fallopian tube at the moment of fertilization. B, blastocyst blastocyst divides into two halves, embryo and placenta. C, fetal heart starts beating around 5th week from last menstrual period. D, fetal hemoglobin has lesser oxygen affinity than hemoglobin A. So if you look at this question, it did not tell you whether you are looking for the wrong answer or for the correct answer. So it's actually left for you now to figure out of all these options, is there one that is, which one is odd? So if you look at it, it says beta HCG is produced by fallopian tube at the moment of fertilization. This is not correct. Then B says blastocysts will divide into two halves, embryo and placenta. This does not also sound right. Then C, fetal heart starts beating around 5th week from last menstrual period. You start to detect fetal heart at the end of the 4th week of development. So by 5th week, you pick a fetal heart. So we know this is correct. Then D says fetal hemoglobin has lesser oxygen affinity than hemoglobin A, which is very wrong because fetal hemoglobin has higher affinity than the adult hemoglobin. So out of all these 4 options, we know that the only correct answer here is C. So C is the answer. Then question 3, indications for forceps delivery may include the following. A, fetal distress. B, fetal prematurity. C, maternal exhaustion. D, maternal brainstem injury or spinal injury. So here too, you have to figure out of all these four options, which one is not an indication for forceps delivery. So if you look at fetal distress, of course, it is an indication for forceps. It can be an indication for forceps. It is an indication for forceps delivery, but prematurity is not. C, maternal exhaustion, yes. When the mother is exhausted, you can assist her and deliver the patient. Then in maternal brainstem injury, when the mother does not have the urge to push, she does not have the strength at all. So that is also an indication it's an indication for forceps delivery. So the only odd option is here is fetal prematurity. Because if the patient is premature, what are you even using the forceps to deliver the baby for? The weight does not even reach that point where you have to assist the mother. So the fourth question here says, regarding cervical cancer screening, regarding cervical cancer vaccine, A, it is trivalent. B, it is protective against all HPV oncogenic viruses. C, it requires 4 doses. D, it is efficacious and safe. So let's discuss a bit about cervical cancer vaccines. There are basically 2 main types of the cervical cancer vaccines. We have the Cervarix and the Gardasil. So we have a bivalent vaccine and a quadrivalent vaccine. So obviously A is out of the way. There is no trivalent vaccine. Then it says the bivalent vaccine, by bivalent, it means it protects against 2 types, it protects against 2 stereotypes of the virus, mostly 16 and 11 and 16. Then the quadrivalent protects against 4 strains of the virus. So not all. And then recently Gardasil 9 has been introduced, which is protective against 9 of these viruses. So not all are protective against all HPV oncogenic viruses. And then regarding the doses, it says it requires 4 doses. This is actually not true, because both Cervarix and Gardasil require 3 doses each. For Cervarix, depending on the age range, for 9 to 14 years of age, you give the first dose at the first visit, and then you give second dose 6 months after the first dose. That is for 9 to 14 years of age, you only give 2 doses. Then for people 15 years and above, you give them 3 doses. You give the first dose at their first visit. Then you give a second dose 1 month after the first dose. And then you give the last dose, which is the third dose, 6 months after the first dose. So that is 5 months interval between the second dose and the third dose. Then for Gardasil, for children 9 to 14 years of age, you also give 2 doses. The first dose at the first visit, and the second dose 6 to 12 months after the first dose. So the difference is you have a gap range here. It can be between 6 months to 12 months, but for Cervarix, it's at 6 months after the first dose. Then for 15 years to 45 years of age, this is where you give them 3 doses of Gardasil. First one is at the first visit, then at second month after the first dose, then 6 months after the first dose. So if you look at these options, it says, A says it is trivalent. We don't have a trivalent vaccine. And then for B, not all are protective against all. For example, Cervarix is protective against HPV types 16 and 18. Then the Gardasil is protective against types 6 and 11, which cause genital warts, and then 16 and 18, which are the ones that can cause cervical cancer. Then for Gardasil 9 that I mentioned, which is newer, it is the one that gives protection against 16, 18, 31, 33, 45, 52, and 58. These are all carcinogenic. Then it also gives protection against 6 and 11, which just cause genital warts. So it depends on the vaccine. Not every vaccine gives full coverage. Then C says it requires 4 doses. We've seen most of them require just 3 doses. Then D says it is efficacious and safe. Of course, yes, it is safe and it is efficacious. So next question says, characteristics of a physiological vaginal discharge. A says Eumeculture proteus mirabilis. Well, it is not part of normal flora of the vagina. Then B says it has a characteristic odor. C, of course, it is not odorless, but then it does not have an offensive odor. So it has a very characteristic odor. So this is true. Then C, pH ranges from 4 to 7. The actual vaginal pH is acidic and it ranges between 4 and 4.5. D, it may be associated with pruritus vulvae. A normal vaginal discharge should not have any form of pruritus. It's unless there's an ongoing infection, that is when you can have pruritus. So B is the answer here. It has a characteristic odor. Sixth question, puerperal pyrexia. Regarding puerperal pyrexia, all is or are true except A, usually due to chlamydia. No, it does not occur as a result of chlamydia. B, usually 48 to 60 hours after delivery. Yes, this is true. It can be as usually due to breast engorgement. Yes, because of inflammatory changes within the breast, it can result in pyrexia. This is correct. Then D is still a significant cause of maternal mortality. Yes, this is true. So the most common cause is mostly as a result of this breast engorgement. And then of course you can have it from other. So A is the answer here. Then we have question 7 regarding vomiting in pregnancy. All vomiting in first trimester are physiological. Well, just because a woman is pregnant, you can't say, so it can as well be pathological. B, hyperemesis gravidarum may be complicated by jaundice. Yes, this is correct. C, hyperemesis gravis. Yeah. D, total parenteral nutrition may be indicated in severe hyperemesis gravidarum. This is as well true. So the only odd option here is A. And then you might be wondering, how does hyperemesis gravidarum get complicated by jaundice? Because as the woman is excessively vomiting, she tends to not take anything orally. So that causes dehydration, and then there will be formation of bile sludge within the gallbladder. That contributes to the formation of the jaundice. It's actually the formation of the bile sludge, and then there's hypermotility in the gallbladder as well. So all those things come together and she can have jaundice. It's actually not very common, but it does occur. Then question 8, risk and vulnerability to HIV in women. A says biological, sociocultural, gender-based, and economic factor increase the risk. B, poverty does not drive epidemics in women. C, in Africa, women are blamed for HIV transmission. D, there are micro tears in the vagina and rectum, which increases the risk of transmission. So here also you have to figure out which one is an odd option in this question. So if you take biological, sociocultural, gender-based, and economic factor increasing the risk, this is true. All these factors can increase the risk for women to contract HIV. Then poverty, B says poverty does not drive epidemics in women. Of course, poverty drives epidemics of HIV in women, because in the poor population, they are at more risk of going into prostitution and rest, so they are at more risk of developing HIV. So and then C, in Africa, women are blamed for HIV transmission. Yes, this is true, women get blamed. And then D, micro tears in the vagina and rectum can increase risk of transmission, which is also true. So the only odd option, which is false here, is poverty does not drive epidemics in women. Question 9, with regard to obstetric history, all is or are true except A, pregnancy is dated from conception. B, parity is the total number of pregnancies regardless of how they ended. C, it is recommended that women should be seen on their own at least once. D, a family history of pre-eclampsia should trigger increased antenatal surveillance. So you are looking for the true, either one or all are true. So A, pregnancy is dated from conception, of course, from the last menstrual period. So this is true. Then parity is the total number of pregnancies regardless of how they ended. That is false, because the definition here is that of gravidity. Gravidity is total number of pregnancies regardless of how they ended. Parity is number of pregnancies carried to age of viability, not regardless of how they ended. C, it is recommended that women should be seen on their own at least once during antenatal visit. Of course, the doctor is supposed to have a one-on-one discussion with the woman at least once during her antenatal period. This is true. Then D, a family history of pre-eclampsia. Of course, this is true because there's a family history of pre-eclampsia is a risk factor for pre-eclampsia. So if the woman tells you that someone in her family has had pre-eclampsia, you should be very careful. Question 10, risk factors for abruptio placenta does not include A, hypertension. Of course, hypertension is a risk factor for abruptio placentae. B, long umbilical cord. Not that I know of. It is not a risk factor. C, smoking. Of course, smoking is a risk factor. Alcoholism, it's also a risk factor. So the wrong answer here is long umbilical cord. Then, so unfortunately, okay. The 11th question says, the following are treatment for choriocarcinoma except A, methotrexate, B, actinomycin, C, cyclophosphamide, D, hysterectomy. So the only thing that will say B is the answer here is because it says actinomycin E. Actinomycin D is the one that is being used for treatment. All the other options are treatment options. And of course, you can either do chemotherapy, radiotherapy, or surgery, or a combination of any of the three for treatment. Question 12 says, most common site of ectopic pregnancy. A, abdomen. B, ampullary portion of the fallopian tube. C, interstitium. D, isthmus. So, of course, the most common site for ectopic pregnancy is B, the ampullary portion of the fallopian tube. About 80% of all ectopic pregnancies occurs there. Then the other percentages are divided amongst the other parts of the fallopian tube. So the highest occurrence is in the ampullary portion of the fallopian tube. Abdominal ectopic pregnancy is the least common site of ectopic pregnancy. Then question 13, incorrect among the following is A, combined hormonal contraceptives may cause excessive weight gain. This is correct. B, high dose OCPs are associated with insulin antagonistic property. Yes, they can. C, combined oral contraceptives can be given in women with history of myocardial infarction. Of course, this is not correct because combined oral contraceptives are contraindicated in anyone with history of myocardial infarction because the COX themselves increase the risk of having myocardial infarctions. For someone to have had an MI and then for you to come and give her again, that will be like trying to kill that woman. So C is not correct. Then D, low dose OCPs do not appreciably increase risk of clinically significant hypertension. Of course, unless if that hypertension is not well controlled, but for women who have well controlled hypertension, they can take very low dose OCPs. 14, oral contraceptives increase risk of all except A, breast cancer. That is correct. B, ovarian cancer. Oral contraceptives are known to reduce the risk of ovarian cancer. C, cervical cancer. Yes, they increase the risk of having cervical cancer. And then D, liver cancer. So oral contraceptives are known to decrease the risk of having ovarian cancer. So B is the answer here. Then question 15, all except one is recommended for use in emergency contraception. A, combined oral contraceptives, yes, they can be used. Progestin only can also be used. Selective estrogen receptor modulators, these are not part of the emergency contraceptive medications. Then D, antiprogestins, they can be used. So the answer here is selective estrogen receptor modulators. Then question 16, all of the following are contraceptive implants except A, Jardel. Yes, it's an implant. Mesigina, this is not an implant, it is an injectable contraceptive. C is a Norplant. Yes, it is an implant. Implanon is also an implant. So the answer here is B. Question 17, the commonest cause of postmenopausal bleeding. A is CA cervix, B CA endometrium, C CA vulva, D ovarian cancer. Of course, the most common cause of postmenopausal bleeding is CA cervix. Don't be confused and say it's CA endometrium. It's actually CA cervix. Then question 18, A, the condom A is a very effective contraceptive. B is an effective prophylaxis for HIV. D is only available for male use. Okay, we missed the option C was missed. Then E is contraindicated in sickle cell disease patients. So of course, it has not said whether one is wrong or so you are supposed to figure out the odd option. So A says it's a very effective contraceptive. It is a contraceptive, but not that very effective because it can tear. So it is not a very effective contraceptive. B is an effective prophylaxis for HIV. Yes, you can protect yourself with the condom from HIV. Then D is an other sexually transmitted diseases. D is only available for male use. Of course, there are female condoms. E is contraindicated. Condoms are only contraindicated to people who are allergic to the condom material, but not contraindicated in patients with sickle cell disease. Unless you are allergic to the material used to produce the condom, then there's no contraindication to its use. 19, the following are differential diagnosis of multiple pregnancy except A, inaccurate date in singleton pregnancy. B, hydatidiform mole. C. Oligohydramnios, D. Polyhydramnios. Of course, if you inaccurately dated a singleton pregnancy, it can appear to be large for gestational age. So this is correct. And hydatidiform moles, one of their characteristics is larger. The pregnancy is larger than gestational age. Then C. Oligohydramnios, of course, it will be smaller than the gestational age, and polyhydramnios. So C is the answer here. The pregnancy in oligohydramnios will be smaller than the gestational age. The fundal height. Question 20, concerning androgen insensitivity syndrome. A, there will be hirsutism. B, there will be male phenotype. C, undescended testes. D, there will be well-developed breast. So you are supposed to look for either the correct one or the wrong option here. So in androgen insensitivity syndrome, what happens is these are male children who have genetic makeup of a male. That is, they have XY chromosome, but their phenotype is that of a lady. They don't have all the external genitalia of normal male individual. Hirsutism is not part of the presentation of androgen insensitivity syndrome. Of course, I just mentioned they have a female phenotype. That is the physical appearance. The outside appearance is that of a female, but the genotype is that of a male. They have XY chromosome. C, of course, they will have an undescended testis because all the external genitalia are not well developed. If you look at them externally, sometimes they are even named girls. They live their life as girls. So the only difference is once they are living the life of a girl, but when you do an ultrasound scan, they will not have female reproductive organs. So they have an undescended testis. And they do not have a well-developed breast. Then question 21, concerning HIV in pregnancy, all is or are true except A, high CD4 increases the risk of mother-to-child transmission. Of course, this is not true. It decreases the risk. And then B, high viral RNA increases the risk of mother-to-child transmission. Of course, this is very true. The higher the viral load, the higher the chance the mother will transmit HIV to the child. Then C, HIV increases risk of transmission of HCV. This is also correct because they are immunosuppressed, so they are at risk of other infections. Then D, when the ruptured membrane for 6 hours is no need for cesarean section. Yes, it has to go longer, 12 hours, for you to start considering cesarean section in HIV positive women. So the wrong answer here is, of course, A, because high CD4 count will decrease the risk of mother-to-child transmission, not increase the risk. (22) says tocolytics. So which of these drugs is a tocolytic, or which of these drugs is not a tocolytic? Ritodrine, of course, it is a tocolytic drug, and by tocolytic meaning a drug. So ritodrine is one. Magnesium sulfate also can be used as a tocolytic. C, nifedipine, which
Sorry, you've lost Dr. Mariam.
So let me share the screen again. Okay, so we were on question 22, which says tocolytic. So which of this drug is not a tocolytic? Ritodrine is a tocolytic drug. Magnesium sulfate as well. Nifedipine 2 can also be used as a tocolytic drug. So the only drug here which cannot be used as a tocolytic is cimetidine. Then question 23, screening and prevention of preeclampsia. A, uterine artery Doppler assessment is done between 15 to 18 weeks. B, triple test. Sorry, please. I'll be back in like 2 minutes. Okay, sorry for the short break. Let's continue. We were on question 23. It says screening and prevention of preeclampsia. A, uterine artery Doppler assessment is done between 15 to 18 weeks. B, the triple test uses combination of biophysical markers, grayscale imaging of the placenta and Doppler ultrasound. C, bariatric surgery can be prevention strategy. D, calcium supplementation is recommended as preventive strategy in all population. So we are to look for either the correct or the wrong answer in this question. So A says uterine artery Doppler assessment is done between 15 to 18 weeks. This is a correct option. Then B, the triple test uses combination of biophysical markers, grayscale. The triple test usually just use maternal features. No feature from the fetus is used. So this is not correct. Then C, bariatric surgery can be prevention strategy. This is wrong. Calcium supplementation recommended as preventive strategy in all population. This is also wrong. It is not recommended for all population. It is only recommended for women who are hypocalcemic and women who have a family history. Then question 24, post-date pregnancy. A, must confirm date after any intervention. B, increased risk of fetal microsomia. C, decreased risk of meconium aspiration syndrome. D, amniotic fluid volume less than 250 mL by 42 weeks. So you have to look for the odd option here as well. That odd option might be the only correct answer or might be the only wrong option. So if we look at it, you don't have to be confirming fetal death after any intervention you do to a pregnant woman. B, actually, the more you try to date the pregnancy, the more you get, the less accurate it becomes. So the best time to date it is in the first trimester. That is the most accurate. Then B, there's increased risk of fetal microsomia. No, it has an increased risk of fetal macrosomia, not micro. Then C, decreased risk of meconium aspiration. This is not correct because one of the risk factors for meconium aspiration syndrome is post-date pregnancy. So that is also not correct. Then D, of course, the more the baby stays post-date, the more the amniotic fluid volume decreases. And by 42 weeks, that amniotic fluid would be less than 250 mils. So this is the only correct option in this question. Then question 25, regarding postnatal clinic visit. A, ensure the child receives his or her immunization. B, counsel the woman on cervical cancer screening. C, start the dose of tetanus toxoid. D, follow up as patient returns back to premenarcheal state. So, of course, when the woman comes to the postnatal clinic, you have to ensure that that child receives his or her immunization. Then B, counsel the woman on cervical cancer screening. This is not on the first postnatal visit. It's actually it's when you are discharging the woman from the postnatal clinic, that's when you will counsel her to have pap smear. Then C, start dose of tetanus toxoid. No. Then D, you follow up patient as patient returns back to premenarcheal state. Of course, that is not correct. So the correct answer here is A, you ensure that the child receives his or her immunization. Question 26, concerning miscarriage. A, it's the delivery of a 400 gram fetus is an abortion. B, septic abortion is not a type of miscarriage. C, 20% of clinically diagnosed pregnancy end as abortion. D, threatened abortion can result to a viable fetus. So here too, you are to figure out. The thing with these questions is they are very tricky. You have to figure out whether you have to figure out an odd option. And then the odd option might be the only correct option, or it might be the only wrong option. So you have to analyze the question. And by analyzing the question, you also have to utilize your time very well. So delivery of a 400 gram fetus is an abortus. Of course, the delivery of a conceptus of less than 500 grams is an abortus. So we know that A is a correct option. Then B, septic abortion is not a type of miscarriage. Of course, septic abortion is not a type of miscarriage. It is a complication of all the other types of miscarriage. It can complicate any other type of miscarriage, but itself, it is not a type of miscarriage. It is a complication. Then C, 20% of clinically diagnosed pregnancies end as an abortion. That is correct as well. Then threatened abortion can result to a viable fetus. Of course, this is not correct, because if you take the definition of abortion, is the termination of pregnancy before the age of viability. So you can't have a viable fetus in abortus. So D is the correct answer. Then question 27, menopause. The menstrual changes include elevation in serum FSH and inhibin. B, there's a higher elevation of LH compared to FSH because FSH is more easily cleared from the body. C, the postmenopausal ovaries secrete higher levels of testosterone than the premenopausal ovaries. D, serum level of estradiol is 10 to 20. So, of course, here too, the same logic for all the questions. So you have to analyze. We know that menstrual changes There's an increase in the level. The menstrual changes include elevation in serum FSH and inhibin. There is an increase in serum level of FSH, but inhibin level declines in menopause. Then B, so why A is incorrect is because inhibin decreases, not increases. It does not elevate. It's only FSH that elevates. B, there's a higher elevation of LH compared to FSH. That is not correct. They are equally elevated. C, if something is to even be more elevated, it will be FSH, not LH. Then C, postmenopausal ovaries secrete higher levels of testosterone than premenopausal ovaries. Of course, this is not correct because testosterone levels also decline during menopause. Then D, the serum level of estradiol is 10 to 20. Of course, there's a lower level of estrogen in menopause, so this is the only correct answer. D is the correct option. Then question 28. The location of the cervical squamocolumnar junction varies with age and hormone status. The squamocolumnar junction tends to evert outward onto the ectocervix during which of the following conditions? A, menopause. We know this is not correct. B, in pregnancy. Yes, there's an eversion. It occurs during pregnancy. C, long-term progestin only contraceptive use. This is not correct. D, all of the above. So we know the correct answer is pregnancy. It's in pregnancy that the squamocolumnar junction everts outward onto the ectocervix. Then 29, ovulation occurs A, after biphasic rise in temperature. B, after the LH surge. C, following follicular stimulation by LH. D, about 14 days before the onset of menstrual cycle. So it's of course almost same logic for all questions. So of course it occurs after the biphasic rise in temperature. Then it occurs after LH surge as well. Following follicular stimulation by LH, that's the LH surge. Then of course the luteal phase is 14 days, but that does not mean it has to occur. It is not for all women. It is for most women, but not for everyone. So that is why E is incorrect here. Then D, drugs used for ovulation induction include A, bromocriptine, B, clomiphene, C, cimetidine, D, danazol. Of course, we all know the drug used for induction is clomiphene. This one is a straightforward question. Then regarding pre-labor rupture of membrane, it is the rupture of membrane in labor. This is not correct. This is prior to labor. Can be complicated by chorioamnionitis. Yes, it can cause ADH. Well, I don't know if this ADH is antidiuretic hormone. Then D says has no significant risk. Of course, it has a very significant risk because this chorioamnionitis can be fatal. So the only odd option here is C, of course. I mean, the only correct option here is B because it has very significant risk. And then it is the rupture of membranes prior to labor, not in labor. So the correct option here is B. It can be complicated by chorioamnionitis. Then 32, in the management of ROM, A, expectant management. Yes, you can advise bed rest and all. Then B, cesarean section is not required. Of course, if it is a life and death situation, you have to do cesarean section to deliver that baby. So it is required. It is part of the management plan. C, use tocolytics in all cases. No, it is not in all cases that you use tocolytics. You only use tocolytics when required. D, use steroids in all cases. You only use steroids when lung maturity has not been achieved by the fetus. But if by the age the prom has occurred, lung maturity has already been achieved, of course, you don't need to give steroids. So the answer here is A. You do expectant management. That is the correct answer. 33. The following drugs are safe during lactation: antineoplastic drugs, anti-cancer drugs. Of course, no, they are not safe. B, radioactive iodine. This is also not safe. Tetracycline. Tetracycline is also not safe in breastfeeding. And what it causes, it causes staining of the teeth, and then it can also retard bone development. Then cephalosporins with antibiotics. These ones are safe during lactation. So D is the correct answer. Then question 34, regarding dating of pregnancy using ultrasound scan. A, first trimester scan is very accurate. Of course, this is correct. B, femur length can be used in the first trimester. The femur is not even there, so it cannot be used in the first trimester. You use crown rump length, CRL. Then C, amniotic fluid index is reversed to date pregnancy. Then D, CRL is reliable in second trimester. Of course, it is not reliable in second trimester. It is only reliable in the first trimester. So the only correct answer here is A. First trimester scan is the most accurate scan. And then in your second trimester, that's when you can start to use your femur length. And why amniotic fluid index is not accurate in dating pregnancy is sometimes there can be polyhydramnios, then there can be oligohydramnios, so it won't actually give you an accurate dating of the pregnancy. Then question 35, risk factors for risk isoimmunization include A, abortion, B, internal cephalic version, C, fetal macrosomia, D, UTI in pregnancy. So of course, we know for rhesus isoimmunization to occur, the fetal and maternal blood has to mix. So of course, it has to be something that can cause bleeding, something a little invasive. So we know internal cephalic version is not an invasive procedure. And then C, fetal macrosomia will not cause the blood to get mixed. UTI, of course, and then abortion. So abortion is the only option here that can result in rhesus isoimmunization. 36, risk factors for rupture uterus include the following except A, fetal macrosomia, B, transverse lie, C, grand multiparity, D, cephalic presentation. Of course, so this is also a bit straightforward. You know, cephalic presentation is not a risk factor for rupture uterus, but all drugs can cause uterine rupture. Then question 37, in twin delivery. So this one has already been highlighted. The first twin is at greater risk than the second twin, and vice versa. This is false. It has already been written there. And then B, cephalic breech presentation is the most common. No, cephalic is the most common presentation. Then C, labor usually occurs prior to term around 37 weeks. Yes, you hardly see a twin gestation being carried to term. It's mostly around 37 weeks of gestation. Then D, labor is extended. No, just because they are two does not mean the labor will be longer than that of a single pregnancy. It is not extended. Then E, there is a risk of retained placenta. That is also false. So the true option here is C. Labor usually occurs prior to term. 38. Multiple pregnancies does not predispose to A, placenta previa, B, diabetes mellitus, C, preeclampsia, D, malpresentation. So, of course, multiple pregnancies can predispose the woman to gestational diabetes. It is also a risk factor for preeclampsia, malpresentation. So the only thing here that the woman doesn't get predisposed to is placenta previa. And the risk factors for placenta previa are previous uterine scar, grand multiparity. These are all what can put the woman at risk of having placenta previa. Anything that has, because with each pregnancy, the placenta looks for a new place to implant. So the more the number of pregnancy, that means the placenta has gone almost around the uterus. So that increases her risk of having placenta previa. Then 39, vaginal candida infection. A is the commonest of all infection during pregnancy. B is not sexually transmissible. C may be treated with erythromycin. D, the color of the discharge is gray. So, of course, you have to figure out the odd option here. A, it is the commonest of all infection during pregnancies. No, UTI mostly is the most common infection during pregnancy. Then B is not sexually transmissible. This is correct. It is not sexually transmissible. C, it may be treated with erythromycin. The most common treatment plan is mostly an antifungal, either cream or a single dose. Then D, the color of the discharge is gray, but when it is a complicated infection, then erythromycin can come into play. The color of discharge is gray. It is often white, cheese cottage appearance. So the only wrong answer here is A, and the answer is A. Then B, the latter sequelae of obstructed labor include following except A, ruptured uterus can occur with obstructed labor, yes. Vesicovaginal fistula, VVF, yes, it can occur as a result of obstructed labor. Osteitis pubis, that can also occur. Then pudendal nerve palsy, that is the one that takes time to occur. All this occur early. All these are early complications of obstructed labor, but pudendal nerve palsy may take some time before it manifests. So D is the answer. In evaluating a patient with galacturia, the following may be required. A, serum prolactin level. Yes, because it is mostly as a result of hyperprolactinemia. B, CT scan of the brain. Yes, it might be a pituitary adenoma. C, transvaginal ultrasound to examine the ovaries. Yes, that is also correct. Okay, sorry about that. The Azan was being called. Let's continue. In evaluation of a patient with galacturia, the following may be required. A, serum prolactin level, yes. B, CT scan of the brain, that's also correct. C, transvaginal ultrasound to examine ovaries, yes. Then D, skull X-ray for frontal sinuses. This is actually not necessary. So D is the answer. Then question 42, premature rupture of membrane. A, patients with PROM after 34 weeks gestation should receive steroids for fetal lung maturity. This is not correct because lung maturity has already been achieved. So any woman with PROM after 34 weeks does not require steroid. Less than 34 weeks, yes, you can give her. B, is typically associated with brief latency between membrane rupture and delivery. Yes, as the membrane ruptures, labor starts to set in. Then C, in utero umbilical cord compression, uncommon. Yes, it mostly occurs outside the uterus during labor. It prolapses down, and then with cord prolapse and then cord compression. Then D, labor should be induced immediately regardless of gestational age in women, in patients with intrauterine infection. So yes, this is correct. If the woman is having an intrauterine infection, regardless of the gestational age, you have to deliver that baby and relieve the woman and treat the infection. So the only false option here is A, because you only give steroids before 34 weeks of gestation, not after 34 weeks of gestation. Question 43, the following is not an indication for cesarean section. A, myomectomy for subserous uterine fibroid. B, obstructed labor. C, fetal distress in second stage of labor. D, previous CS with breech presentation. So which one is not an indication for cesarean section? Of course, why would you do cesarean section for myomectomy? So A is the answer. 44, the following is true about PPH, postpartum hemorrhage. PPH is highly predictable because only 50% of cases have identifiable risk factor. B, uterine rupture accounts for 70 to 90% of PPH cases. C, active management of third stage of labor can prevent 60% of uterine atony. It is uncommon on grand multiparous women, so we are to look for the odd option. Yes, PPH can be predictable, but not up to 50% of cases will have an identifiable risk factor. You can identify women who are at high risk, but not up to 50% of them will have an identifiable risk factor. Then B, uterine rupture accounts for 70 to 90% of PPH cases. No, this is not correct. The most common cause is uterine atony, not rupture. Then C, active management of third stage of labor can prevent 60% of uterine atony. Yes, this is correct. Then D, it is uncommon in grand multiparous women. Of course, grand multiparity is one of the risk factors that puts a woman at having PPH. So C is the correct answer here. It is the only correct option. Then question 45, contraindication to magnesium sulfate, except A, renal disease, B, hypocalcemia, C, myasthenia gravis. D, hypomagnesemia. Of course, yes, you don't give magnesium sulfate to someone with renal disease, someone with hypocalcemia, or someone with myasthenia gravis. So, but you can give magnesium sulfate to treat hypomagnesemia. So D is the correct answer. Then menstrual cycle, regarding the menstrual cycle, which is not correct? A, progesterone mitigates the trophic effects of estrogen on endometrial epithelium. B, dysfunctional uterine bleeding may result from failure of ovulation. C, an unfertilized egg dries up and leaves the body about 2 weeks after ovulation through the vagina. D, progesterone increases maternal immune response during implantation and gestation. So you have to look for the option that is not correct. Progesterone mitigating trophic effect of estrogen on endometrial epithelium. This is correct. Of course, dysfunctional uterine bleeding can result from failure of ovulation. This is also correct. Then, of course, an unfertilized egg, it will dry up and then it will leave the body after about 2 weeks. About 2 weeks after ovulation. That is correct. Progesterone increases maternal immune response. No, it actually decreases the maternal immune response so that the blastocyst can implant. So it is decreasing the maternal immune response, not increasing. So D is the option that is not correct. Question 47. The protective bacterium in the vagina is called A, E. coli, B, Peptostreptococcus, C, Lactobacillus, and D, Gardnerella vaginalis. Of course, the protective bacterium of the vagina is Lactobacillus. Question 48. The following pubertal events will occur even in the absence of ovarian estrogen production. A, telarche, B, menarche, C, puberty, D, nail growth. So which one occurs irrespective whether there is ovarian estrogen production or not? The one that occurs here is puberty. That is the appearance of pubic hair. That one is independent of estrogen production. But telarche, menarche, yes, they are all in response to estrogen. But puberty does not require estrogen, and that is the appearance of pubic hair. Rhesus positive refers to A, presence of D antigens on the surface of red blood cells, B, presence of rhesus antibodies, C, presence of D antigen on the surface of white blood cells, and D, absence of both D antigens and antibodies. Of course, for a person to be rhesus positive, that means his red blood cells have D antigens on their surface, not rhesus antibodies. That is isoimmunization. But this positive means presence of D antigens. Then question 50. A 20-year-old prima gravida at 38 weeks gestation complains of mild headache and leg swelling. Her blood pressure is 160 by 100 millimeter of mercury. Her urinalysis is likely to show. So if you look at all these symptoms, what they are trying to picture for you is preeclampsia. So she already has headache, she has a high BP and has edema. So what you are looking for in the urine, of course, you know you are looking for protein. So A, proteinuria, that is true. B, hematuria, which is false. C, glycosuria, and leukocyturia. So the correct answer, it has already been shown, is proteinuria. So we've answered 50 questions. I don't know, maybe we should have, maybe if you have any questions, we get them clarified and then we see if we are to continue with the MCQs or if we should look at the picture tests. I think you can unmute yourselves and then let's decide what we are to continue. Let's see. So if you have any question, you can unmute yourself and ask. Is there anyone with question? Should we continue or should we look at picture tests? Which one do you prefer?
Maybe we could check for do the picture tests.
Okay, what of the rest? What do you think? And then I know today is Friday. So when should we have the break? Because I know the male students are going to go to the mosque. So are you with us? So I only had one person's response actually. So I will assume you don't have any questions, you don't have any clarification. Because everyone is quiet. Even though I've allowed you to unmute yourself and ask questions. Okay, then let's take some of the picture tests. And then maybe after prayers, we can complete the MCQs. So the first question here says, what is the primary purpose of using an anti-shock garment in the management of postpartum hemorrhage? A, to provide warmth and comfort to the patient. B, to prevent infection at the site of hemorrhage. C, to immobilize the patient. Sorry, do you have a question? Then C, to immobilize the patient and prevent further bleeding. D, to aid in controlling and reducing blood loss. So, of course, the correct answer here is D. You are trying to control and reduce the blood loss that the woman is having. So I think since this one is a picture test, let's make it an interactive session. But the thing is, you are all not saying everything. I would really love an interactive session. So please, let's interact. Let's remember, let's say one or two things about postpartum hemorrhage. Can you unmute yourself and let's discuss? What is PPH? When do you say is woman is having PPH? How do you classify PPH? You know it is an obstetric emergency. Or do I have to be picking names? Dr. Yahaya, you seem to be the captain of this team, but none of you is saying anything.
Money, I use another. I collect.
Yeah, please unmute yourselves. Let's interact. It's going to be more interesting. Because this way it's more of like I'm just talking to myself.
That's what we are hearing.
Are you still
We are with
unable
you.
to unmute yourself? No, you can unmute yourself. So what is postpartum hemorrhage? I don't know, maybe you just want to be answering the questions, right? You are not interested in the discussion.
Postpartum hemorrhage is excessive bleeding after childbirth.
Yeah, can you quantify it?
500 mils in more than 500 mils in spontaneous vaginal delivery, and more than 1,000 mils in cesarean section.
Yes. And then we have primary postpartum
Yes,
hemorrhage and secondary postpartum hemorrhage.
yes, sir.
And then it can as well be minor or major.
Yes, sir.
Minor blood loss is less than 1,000 mil, and then major is more than 1,000. And then it complicates like 5 to 8% of vaginal deliveries. So I think let's continue, since the rest are not willing to unmute their mics. But then what of some risk factors?
This factor of postpartum hemorrhage, trauma, trauma, tissue thrombin, and trauma.
Those are the causes, the 4 T's that you mentioned. Those are the causes of PPH. But for risk factors, you have like risk factors like multiple pregnancy, grand multiparity, a woman who had coexisting fibroids along with the pregnancy.
And maybe placenta previa, right?
Yes.
And
Yes, abruptio, precipitated labor.
retained placenta.
Yes.
Maybe a macrosomic baby.
Yes. Multiple gestation.
Older maternal age.
Yes, fetal anomalies can also cause it. And of course, previous history of PPH is also a risk factor for PPH. If she has had a previous uterine surgery, that puts her at risk as well.
Preeclampsia.
So let's continue. Yeah. So question 2, how does an anti-shock garment help manage postpartum hemorrhage? A, by administering medication directly to the bleeding site. B, by applying pressure to the abdomen and pelvic area. C, by promoting uterine contractions to stop the bleeding. D, by providing psychological support to the patient. So what do you think is the answer here?
I think it
How does
applies pressure to the abdomen and pelvic area.
Yes, that is correct. So B is the answer here. If I can remember, in my own MDCN, we got this anti-shock garment. So question 3, when is the most appropriate time to initiate the use of an anti-shock garment in postpartum hemorrhage cases? A, immediately after childbirth. B, 24 hours after childbirth. C, when the bleeding becomes severe. D, at the discretion of the healthcare provider. So when do you think you should initiate the use in PPH? This is a woman, she has delivered, you have seen that there is PPH. When are you to apply the anti-shock garment? When do you think you should put on the anti-shock garment? Is it immediately after she has given birth, 24 hours, or when the bleeding becomes severe, or when you feel it is right as her doctor? Let's attempt. It's okay if you attempt and it's not right. Yes. So if you know that this woman is at risk of PPH, or you already see that PPH has started, you put it immediately after she has given birth. You don't wait until the bleeding becomes severe or when you feel it is all right. And then, of course, if you wait 24 hours, the woman might even be dead. So the answer is A, immediately after childbirth. Then question 4, which of the following best describes the mechanism of action of an anti-shock garment in postpartum hemorrhage? A, facilitating blood transfusion to replace lost blood. B, supporting the patient's emotional well-being. C, applying pressure to compress blood vessels and reduce bleeding. D, preventing the formation of blood clots in the uterus. We've already answered a similar question. So what do you think is the answer here?
C, applying pressure to compress the.
Yes, that is correct. Question 5, what are the potential risks or complications associated with the use of anti-shock garments in postpartum hemorrhage management? A, increased risk of infection. B, decreased blood pressure. C, allergic reactions to the garment material. D, delayed healing of the perineal area. So what do you think can result as a complication? Can it increase risk of infection? You are not introducing anything to the woman. So less likely. Decreased blood pressure. Of course, you are compressing the blood vessels, you are compressing the woman, you can lower, the blood pressure can lower down. And then she's also losing blood. So that as well can lower the blood pressure. So B is a likely complication. And then allergic reactions to the garment material, that I have not heard of. Then delayed healing. You are not leaving it on the woman to last like forever. It's for some period of time when you feel she's safe to be out of it. So B is the answer here, decreased blood pressure. The instrument on display is, what is this instrument? Let's start from there.
Peanut stethoscope.
Yes, or stethoscope. So, the instrument on display is commonly used in obstetric practice. A, will detect fetal heart deceleration. Will it detect fetal heart deceleration?
No?
Then B, it is used every 15 minutes in the second stage of labor. Is this true?
No.
Every how many minutes?
30 minutes.
Yes. Then C, more effective in polyhydramnios.
No.
Then that means all are incorrect.
Yes.
So D is the answer. The below is called, what is this? What is the displayed image?
Common syringe.
Syringe.
Yes, it is a common syringe. And what is it used for?
Manual vacuum aspiration.
Aspiration.
So you have already answered this question. What is the common syringe primarily used for in gynecology? We've already mentioned it is used for manual vacuum aspiration.
Yes.
And by the way, these cannulas, they are numbered, they are color coded depending on the sizes. So you see the yellow is the smallest. And you start from the lowest and then you keep increasing the numbers. Question 9. How does the common syringe function during the procedure of manual vacuum aspiration? A, it delivers controlled bursts of carbon dioxide into the uterus. B, it creates a vacuum to gently remove the contents of the uterus. C, it measures the intrauterine pressure during labor. D, it facilitates the insertion of intrauterine devices. So how does it function during MVA? What is the mechanism?
It's pressure. It's rate pressure which is calculated.
So which option are you saying? Because you are saying pressure.
B.
C?
B.
Sorry, I can't hear you well.
B.
B for boy or D for dog?
B for boy.
Ah, okay, yes. So it creates a vacuum and then it gently suctions the contents within the uterus. Question 10. What is the primary purpose of using misoprostol tablets in healthcare? A, pain relief for menstrual cramps. B, induction of labor. C, treatment of gastroesophageal reflux disease. D, prevention and treatment of postpartum hemorrhage. So which one is the primary purpose?
Induction of labor.
Anyone with another option? Do you realize that misoprostol can be used for all these 4 things?
Yes.
Yes, it can be used for all the purposes.
It can be used, yes.
But the primary purpose is actually for prevention and treatment of postpartum hemorrhage. That is the primary purpose of its use. All others are additional uses. So D is the answer here. What is the recommended route of administration for misoprostol tablets in the prevention of postpartum hemorrhage? A. Oral administration. B. Intramuscular. C. Vaginal. D. Sublingual. Which one is more effective?
Vaginal.
Yes, vaginal is the most effective, although nowadays sublingual is being used, but the vaginal is the recommended route. So question 12, how does misoprostol tablet help prevent postpartum hemorrhage? A, by stimulating uterine contractions. B, by promoting blood clotting. C, by reducing blood pressure. D, by preventing infection at the site, at the delivery site.
A.
So how does it? How does it prevent PPH?
By stimulating uterine contraction.
Yes. So that way you tackle uterine atony, which is a major cause of PPH. So identify the instrument.
Speculum.
A speculum and a retractor.
More attempts. Where are the rest? Why is it only one person or two? So which one is the speculum? Which one is the retractor?
They're saying they can't unmute themselves.
That was because before I allowed them to unmute themselves, but let me see. Okay, I'll allow you to unmute. Please unmute yourself. Yes, you can. Okay. So please identify A. What is the instrument? What is the instrument A?
Speculum.
What type of speculum?
Speculum. Cuscus speculum.
Then what of B?
Sims.
Speculum.
So both are speculums. A is cuscus, B is Sims. So which one will you use in the following procedures in inserting an IUCD?
Cuscus.
In vaginal hysterectomy?
Sims.
Yes.
Sims speculum.
Yeah. In D and C?
Cuscus speculum.
Yes. In obtaining a pap smear?
Cuscus.
Repair of a cervical tear?
Sims.
Yes. So the difference is cuscus is self-retracting, while B is not a self-retracting, it's not a self-retaining retractor. But both are retractors. So what can you see?
A uterus.
Yes, this is a uterine specimen. What can you see inside the uterus?
Adhesions.
Dr. Mariam, you should unmute yourself. Dr. Mariam, you are still muted. We can't hear you.
Yes, sorry. The background was a bit noisy, but we can continue now. So, have you seen the intrauterine device? Or have you all muted yourselves? So question 15 says, name the 3 types of breech illustrated. Name 2 maternal causes of breech, 2 fetal causes. So what are these 3 types of breech?
A is frank or extended.
B is
B
complete.
is flexed or complete.
Complete breach.
And
And
C
then
is
C is
footling
footling.
or incomplete.
So A is frank breech. B,
Is
what
complete
did you say B is?
complete breach.
Complete.
Yes, B is a complete breech. And then C,
Footling.
yes, that is a footling breech. So what? Mention 2 maternal causes of breech presentation.
Maternal fibroid.
Yes. Another cause.
Previous history.
Come with another one. There are better.
Maternal diabetes.
Uterine anomaly.
We are okay. Yes, uterine anomaly can. Uterine abnormalities can cause. Let's come up with more maternal causes.
Placenta previa.
Yes.
Contracted pelvis.
Yes. Then you forgot to mention the most important one. It can be idiopathic without any reason. The baby can just be breech. Sorry, please, I'm coming. Just let's have a 5 minutes break.
So, hello everyone. We can actually take the break for today because it's Friday, and go for our Jumat prayers. Then, let's say by 1:30 we'll resume and continue. So we are going to complete both the ONG as well as the community medicine. If time permits, we take medicine in the evening before pediatrics. So I'll drop a message. We are going to resume by, is it 1:30 or 2 o'clock now? What time?
No. Let's 2.
2 o'clock.
2.
2 o'clock. Okay. Okay.